I want you to imagine an architectural paradox for a second. Just picture a specific type of building design that is rarely used. Like maybe only 1 in 5 buildings is actually constructed this way.
Okay, I'm picturing it.
Right, but here is the catch. When this specific design is utilized, the building is somehow structurally doomed. I mean, it collapses much faster and under significantly less physical stress than all the standard designs surrounding it.
Wow. Well, you'd assume the structural engineers would, immediately pull the blueprints, like isolate the materials and completely halt construction until they figured out the fundamental mechanical failure.
Exactly. But in the human body specifically, when we're looking at an abdominal aortic aneurysm, or AAA, the medical field is, well, they're still wrestling with that flawed blueprint.
Yeah, they really are.
Because if you look at the raw epidemiology, AAA is heavily skewed as a man's disease. It affects men, like 4 to 1 over women. But for the women who do develop this aneurysm, their outcome maps directly to that doomed architectural design we just talked about. They face a 3 to 4 times higher risk of rupture, significantly faster aneurysm growth, and drastically higher mortality rates.
Which completely flips the baseline assumptions about cardiovascular risk profiles. I mean, the sheer velocity of the disease progression in women, it forces us to look beyond basic hemodynamics.
Right, and that is exactly the mission for this deep dive. I'm your host, and I'm joined by a resident medical expert to break this all down.
Hi, everyone. Really glad to be here for this one.
So for you listening, if you are looking to understand the why behind this stark disparity in medical data, we are going to explore exactly how the sudden drop in systemic estrogen during menopause just structurally dismantles the aortic wall in women with a known AAA.
It's a fascinating cascade.
It really is. And the very first concept that surfaced in our sources, and arguably the most ironic part of all this, is the timing hypothesis.
Yeah, the irony there comes from the temporal nature of the hormones. Because premenopausal estrogen is deeply vasoprotective, it actively maintains the integrity of the vascular extracellular matrix.
It's basically a shield.
Exactly, a very effective shield. And the clinical assumption for years was pretty simple. They thought if a woman loses estrogen during menopause, we just give her a hormone replacement therapy, or HRT, right, like in her 60s or 70s to restore the baseline.
Which seems logical on paper.
It does. But the data shows that initiating HRT years after menopause does not reverse the AAA progression. And in many cases, it actually exacerbates overall cardiovascular risks.
Oh, wow.
Yeah. The protective window essentially closes.
So to understand why that shield vanishes permanently, we really need to look at what the aortic wall relies on for survival. Because we aren't just talking about a static pipe here, right?
No, not at all. This is a muscular vessel. It's absorbing the immediate, immense hydraulic force of blood ejecting straight from the heart.
Right. And its extracellular matrix relies heavily on collagen to provide structural tensile strength.
Right.
And elastin to allow for the mechanical recoil after every single heartbeat.
Which is a huge mechanical load. And within that dynamic vascular wall, there is a constant cycle of tissue remodeling. It's mediated by these enzymes called matrix metalloproteinases, specifically MMP2 and MMP9.
Okay, MMPs. What exactly are those doing?
They are zinc-dependent endopeptidases. Basically, their primary function is the degradation of type IV collagen and elastin.
Wait, so they actively break down the wall?
They do, but they are a necessary part of cellular turnover. You need old tissue to be cleared out for new tissue, but their proteolytic activity has to be tightly suppressed. If it isn't, they will simply digest the vessel from the inside out.
Okay, and this is where estrogen comes in. Premenopausal estrogen is the agent providing that suppression, right?
Spot on. It actively downregulates the gene expression for these destructive MMPs.
It's like a highly strict site manager at a construction zone. Like, as long as that manager is walking around with a clipboard, the demolition crew, the MNPs, are kept on a very tight leash.
That's a great way to picture it. They only perform the precise, localized maintenance they're actually authorized to do.
Right. But when menopause hits and that manager permanently retires, the biological inhibition is just lifted. The crew goes rogue and begins aggressively dismantling the building's main support beams.
Exactly. You see a massive surge in local proteolytic activity within the arterial wall. The enzymes actively thin the meaty layer of the aorta.
Which is terrifying because the pressure doesn't stop.
No, the vessel is still under the constant rhythmic pounding of systolic blood pressure. So that sudden structural thinning is the precise trigger for rapid aneurysm expansion. The mechanical load just completely overwhelms the degraded elastin fibers.
But the structural degradation doesn't stop at just a lack of estrogen, does it? The research details this biological feedback loop where the drop in estrogen actively triggers a surge in a completely different hormone.
Right, it's a compounding issue. When the ovaries cease estrogen production, the anterior pituitary gland senses the deficit, so it pumps out chronically high levels of follicle-stimulating hormone, or FSH.
To try and wake the ovaries up.
Exactly. The goal is to stimulate the depleted ovaries, but the collateral damage happens in the blood vessels.
Wait, let me stop you right there. Follicle-stimulating hormone. Isn't that strictly for reproduction? Like, how is a fertility hormone chewing through the wall of an artery?
That was the medical consensus for decades. Everyone assumed FSH receptors were localized entirely to the gonads. But the turning point in the recent literature is the discovery of extragonadal FSH receptors.
Meaning they are outside the reproductive system?
Yes. They are expressed directly in the vasculature, on endothelial cells, and critically on immune macrophages.
Okay, but if extragonadal FSH receptors are present throughout the entire vascular system, why is the catastrophic damage so localized to the abdominal aorta? Like, why aren't women experiencing spontaneous arterial collapses all over their bodies during menopause?
That is the million-dollar question. It's because the FSH surge requires a very specific local environment to become destructive. An abdominal aortic aneurysm doesn't form in pristine tissue.
Right, it's already damaged.
Exactly. The aorta is already diseased. It's often highly calcified and inflamed, which acts as a beacon for circulating immune cells. So macrophages flood into the adventier, that's the outer layer of the artery, to clear out the necrotic debris.
Okay, I'm following.
So when those localized macrophages are suddenly bombarded by the systemic surge of FSH during menopause, the activation of their FSH receptors triggers a transdifferentiation process.
Wait, transdifferentiation, they change their cellular identity entirely.
They do. The FSH physically programs these immune macrophages to transdifferentiate into osteoclast-like cells.
Osteoclasts, those are bone cells, right?
Yes, bone-resorbing cells. They take on the morphology and the biological function of bone cells right there in the arterial wall, because the calcified environment of the diseased aorta essentially mimics a skeletal environment. It creates a perfect storm.
Wow. Okay, so let me get this straight. You have the estrogen site manager retiring, which unleashes the baseline MMP demolition crew.
Right.
Concurrently, the pituitary gland starts broadcasting FSH systemically, which recruits a specialized bone-eating demolition crew straight into the diseased arterial tissue.
That is exactly what is happening. And once those osteoclast-like cells are active, they secrete enormous amounts of cathepsin K.
What is cathepsin K?
It's a protease specifically evolved to degrade bone matrix and robust collagen networks. They also secrete additional MMP9. So the extracellular matrix is subjected to this profound, multi-front enzymatic assault that the premenopausal aorta simply never had to defend against.
Yeah, and the wall is just structurally failing on every level. But the environment inside the artery is simultaneously becoming more hostile too. Like, the tissue isn't just weakening, it's being subjected to increasing internal mechanical stress.
Yeah, we have to look at the pressure side of things.
Let's talk about the renin-angiotensin-aldosterone system, or the RAAS pathway. Because the sources say this is heavily modulated by estrogen, specifically through the angiotensin II type 1 receptor, or AT1R.
Right, so estrogen normally acts as a powerful suppressor of AT1R expression in the vasculature.
It keeps it turned down.
Exactly. So when systemic estrogen levels plummet, AT1R expression spikes dramatically. This means when angiotensin II binds to these newly abundant receptors, it triggers severe, sustained vasoconstriction.
The vessels just clamp down.
They do. And this elevates systemic blood pressure, yes. But more dangerously, it drives localized fibrosis and places massive biomechanical stress directly onto the thinned, compromised wall of the aneurysm.
So the AT1R spike handles the pressure side of the equation. But looking at the oxidative stress component, the mechanism involving ENOS seems almost counterintuitive. I mean, it's an enzyme designed for protection that essentially gets weaponized.
It really does. So ENOS, or endothelial nitric oxide synthase, is heavily dependent on estrogen for its optimal function and for the availability of its essential cofactors.
And normally it does what?
In a healthy premenopausal state, ENOS produces nitric oxide. That's a highly potent vasodilator that keeps the endothelium flexible, relaxed, and protected from leukocyte adhesion. It is a critical antioxidant defense mechanism.
But without estrogen maintaining that molecular structure, the enzyme physically uncouples, right?
Yes. The uncoupling of enos means that instead of reducing oxygen to synthesize nitric oxide, the enzyme starts transferring electrons directly to molecular oxygen.
Which means it makes something else.
Right. It shifts from producing a protective gas to mass-producing superoxide. These are highly reactive oxygen species, or ROS.
It's like a municipal water purification plant experiencing a mechanical failure, reversing its gears, and just pumping toxic sludge directly back into the town's water supply.
That is a very accurate, albeit gross, analogy. That flood of free radicals obliterates whatever residual vasoprotection was left in the endothelial layer.
Wow.
The superoxide reacts with any remaining nitric oxide to form peroxynitrite, which is a highly cytotoxic oxidant.
So it's actively killing the cells.
Yeah, and this profound oxidative stress creates a massive localized inflammatory response. That inflammation acts as a biological siren, drawing even more macrophages into the adventitia.
Oh, and then those macrophages are exposed to the high FSH levels.
Exactly. They transdifferentiate into osteoclasts and accelerate the structural degradation. It is a closed-loop cycle of destruction.
To synthesize this dual threat scenario for you listening, it's like, well, the loss of estrogen does two catastrophic things simultaneously. It takes a flexible rubber garden hose and lets it sit out in the blazing sun until the material becomes dry, cracked, and brittle. That represents the extracellular matrix degradation from the MMPs and the bone-eating osteoclast cells.
Right.
But then, concurrently, it cranks the water pressure to the absolute maximum, which represents the AT1R vasoconstriction and the enos-driven oxidative stress. The hose is subjected to maximum force at the exact moment of its minimum structural integrity.
And with the wall actively thinning and the internal pressure spiking, the tissue simply cannot hold.
So when a surgeon actually opens up a patient and examines this tissue on the operating table, what do they physically see compared to a male aorta? Because the biochemical data points to a very specific metric called the HPLP ratio.
Yeah, the HPLP ratio measures the proportion of hydroxylpyridinoline to lysylpyridinoline.
Okay, what does that actually mean for the tissue?
It's a direct quantification of collagen cross-linking. Cross-linking is the biological process of weaving individual collagen fibers into tight molecular knots. This is what generates tensile strength and dictates how well the tissue can resist tearing forces.
So it's how tightly the fabric is woven together.
Precisely.
And the tissue samples from women with AAA show a significantly lower ratio.
Yes, a lower ratio indicates immature, unstable crosslinks. The collagen matrix in a woman's aorta is physically less tightly woven and biomechanically weaker than the collagen network in a man's aorta.
That is wild.
The steel rebar of the vessel is fundamentally a lower structural grade because the estrogen necessary to facilitate mature cross-linking is gone.
The clinical data reflects this anatomical vulnerability with brutal clarity, too. The Vascular Study Group of New England, or VSG&E, they maintain this massive registry tracking elective and emergent AAA repairs. And when you look at the rupture sizes, women's aortas are tearing at significantly smaller diameters.
They really are.
I mean, the median rupture size for women was 71 millimeters compared to 79 millimeters for men.
That's nearly a full centimeter smaller. And in vascular surgery, a centimeter of diameter is a massive difference in volumetric pressure and wall tension, according to Laplace's law. The tissue is yielding at much lower mechanical thresholds.
Which begs the obvious clinical question. If the vascular surgery community knows that women's aortas are biochemically weaker due to these cross-linking failures, and the registry data proves they are rupturing at smaller sizes, why are the surgical guidelines for women largely identical to those for men?
It's a huge point of contention.
Like, why wait for a woman's aneurysm to reach a 5.0 or 5.5 centimeter threshold before intervening?
Well, the historical guidelines for elective repair were established based on massive population trials that heavily skewed male. The 5.5 centimeter threshold was calculated as the exact inflection point where the statistical risk of the aneurysm rupturing finally outweighed the statistical risk of perioperative mortality from a major vascular surgery.
But that was male data.
Exactly. The failure was applying male biomechanical and mortality data to female patients. Waiting for a structurally compromised female aorta to reach a male-sized threshold is precisely why women experience rupture while under active clinical surveillance.
They're literally waiting for a metric that doesn't apply to their biology.
Yeah.
And even when the decision is made to operate, getting a woman to the operating room doesn't neutralize the risk.
Not at all.
The VSG&E data outlines severe perioperative complications. During an open surgical repair, women experience significantly higher rates of leg ischemia, which is a loss of blood flow to the lower limbs, and bowel ischemia.
Right, and those complication rates are driven by a convergence of the weakened arterial wall and baseline anatomical differences, because women naturally present with smaller iliac and femoral access arteries.
And the surgical tools are largely proportioned for male anatomy, right?
Yeah, that's a massive issue. When surgeons perform an endovascular aneurysm repair, an EVR, they are navigating large, complex stent grafts through the femoral arteries up into the aorta.
And these devices are bulky.
Very bulky. So when you attempt to force a delivery sheath designed for an average male through a narrow, tortuous, highly calcified female iliac artery, the friction is immense.
Which leads directly to the data. Women experience double the rate of major arterial injury during EVR procedures.
Yes, the sheath physically tears the fragile intimal lining of the access vessels, or it dislodges atherosclerotic plaque, which embolizes downstream and starves the legs or the bowel of oxygen.
It is just a perfect storm of a biologically degraded vessel wall, narrow vascular access routes, and mismatched medical devices.
It really is. And it comprehensively explains why the 30-day mortality rate after both open and endovascular repairs is disproportionately high for female patients. The surgical intervention itself inherently carries more trauma for their specific anatomy.
Looking at the entirety of this cellular and biomechanical cascade, it completely reframes the concept of menopause in cardiovascular medicine. Like, it requires moving far past the simplistic idea of just losing a protective baseline.
Absolutely. The loss of systemic estrogen is an active trigger. The withdrawal lifts the suppression on the MMP enzymes, initiating the breakdown of collagen and elastin.
And then the pituitary gland attempts to compensate, flooding the vasculature with FSH, which locates those extragonatal receptors on macrophages, physically programming them into bone-eating osteoclast cells right inside the arterial wall.
Yeah. And while the extracellular matrix is being dissolved by proteases and cathepsin K, the uncoupling of the ENO-S enzyme transitions the tissue environment from vasoprotective nitric oxide to cytotoxic superoxide.
And the sudden spike in AT1R expression clamps the vessels down, driving systemic pressure and mechanical stress directly into the thinned, failing tissue.
So treating a female patient with a 4.5 centimeter aneurysm the exact same way you treat a male patient with a 4.5 centimeter aneurysm is, frankly, to ignore this entire interconnected physiological cascade.
For you listening, this really highlights the profound danger of treating male and female bodies as identical in clinical practice. Taking a disease that predominantly affects men, studying it mostly in male cohorts, and unilaterally applying those surgical thresholds and device parameters to women actively causes harm.
We have to move past it. The paradigm has to shift from watchful waiting based on male metrics to active management based on female biochemistry.
Exactly. Understanding the nuances of this hormone-driven structural collapse is the only viable path toward personalized, life-saving intervention, which actually makes me wonder about the future of pharmacological treatment.
Oh, how so?
Well, we've established that chronically high FSH, combined with an inflamed vascular wall, creates a specific osteoclast-driven degradation, right?
Right.
Currently, clinical surveillance for small aneurysms mostly involves prescribing standard blood pressure medications to reduce mechanical stress while waiting for the aneurysm to grow. But if the root mechanism destroying the extracellular matrix is mediated by extragonatal FSH receptors, it seems like we are ignoring the actual demolition crew.
That's a really interesting point.
Right. What if future therapies bypass traditional hemodynamics entirely? If we could synthesize a targeted FSH receptor antagonist specifically for the vasculature, we might be able to halt the transdifferentiation of those macrophages.
You could theoretically shut down the release of cathepsin K.
Yes, and physically freeze the aneurysm in its tracks before it ever reaches a surgical threshold.
If you can neutralize the signal that turns an immune cell into a bone-resorbing cell, you preserve the cross-linked collagen. You essentially secure the building's foundation before the pressure has a chance to bring it down.
A completely different blueprint for structural repair. It's definitely something to think about as you navigate this research. Thank you so much for breaking this all down with me.
My pleasure. It was a great conversation.
And thank you for listening to this deep dive. We'll catch you on the next one.